What's up, Ninja Nerds? In this video today, we are going to be talking about restrictive lung diseases. Lots to talk about, so let's go ahead and get right into it. So the first thing that we have to talk about, like every video, is the types of restrictive lung diseases, the causes, and some of the pathophysiology behind that. Let's take a quick look at the pathophysiology, because thankfully, in comparison to obstructive, it's not that intense. You're like, oh, thank goodness. Yeah, it's not really that bad. So what I want you guys to understand is a patient who has a restrictive lung disease, there's some type of exposure to various amounts of triggers, and that's where restrictive lung disease can be somewhat complicated. But when we talk about restrictive lung disease, the pathophysiology is straightforward. There's some type of trigger or exposure, and we'll talk about all those below. Here's this trigger that we're gonna say, right? These blue antigens, if you will. Once the trigger gets into the actual pulmonary system, it becomes exposed to alveolar macrophages. These alveolar macrophages, when exposed to these antigens or triggers, they become activated. You know, generally when they become activated, they present a piece of that antigen on their MHC2 complexes and express it to T cells, and that activates an entire immune response. That's what happens. These macrophages start producing lots and lots and lots of cytokines, inflammatory cytokines. There's so many of them. I don't think it's that pertinent to talk about them though. Well, what I want you to know is there's many, many different cytokines. And what these do is they alert the immune system. They activate or stimulate neutrophils to come to the area. They activate and stimulate more T cells to come to the area. And this propagates a worsening immune response. Now, here's what's interesting. Whenever there's a lot of this inflammation, because neutrophils will come to the area and they're going to start releasing proteases and reactive oxygen species. You're going to have T cells coming to the area releasing lots of other types of cytokines and maybe even making some immune complexes. But all of these things are going to just propagate lung injury. Whenever there is injury to the lung tissue, repeated injury to the lung tissue, what happens is this stimulates these special cells within the lungs. You know, there's these cells called fibroblasts. So here we have these orange cells here. These are called fibroblasts. Now what happens is from repeated lung injury due to this particular trigger, the fibroblasts become stimulated by these inflammatory cytokines. And they start producing lots and lots and lots of fibrous tissue. And what this fibrous tissue does is it starts actually depositing into the actual lung parenchyma. And this includes a lot of different parts of the actual lung parenchyma. We used to call these interstitial lung disease, meaning it only deposited in the interstitial spaces. But we found over time that it can actually deposit into the visceral pleura, it can deposit around the bronchioles, it can deposit into the alveoli, it can deposit into the interstitial spaces, around the pulmonary capillaries. So we call these diffuse parenchymal lung diseases now. But it's very diffuse fibrosis. So you're going to get a ton of fibrosis of the lungs. Why is that problematic? Well, imagine you have these super fibrotic lungs that don't really want to be able to have much give. If they don't have much give, that's a problem because the lungs are supposed to be easy to stretch and be compliant when you take a breath in. But if they're very fibrotic, the lung compliance drops significantly. Their ability to stretch is reduced. And subsequently, if you reduce their ability to stretch, you reduce their ability to be able to inflate and take in air. And so there is a significant reduction in the inflation ability of the lungs. And so we call restrictive lung disease the diseases where they aren't able to take in or inhale as much volume of air in comparison to the normal lungs due to excessive fibrosis. Now, here's the big thing. When we talk about restrictive lung disease, we can actually put them into two categories: pulmonary disorders, and we actually like to call these intrinsic pulmonary disorders, meaning that there is a disease involving some of the lung parenchyma. Maybe there is fibrosis around the bronchioles. Maybe there is fibrosis around the alveolus. Maybe there's fibrosis all in this interstitial space. Maybe there's fibrosis of the pulmonary capillaries. If it involves any of this tissue, we call this the lung parenchyma tissue. So all of these that we just mentioned, this is the lung parenchyma. And whenever there is fibrosis of the lung parenchyma, we call this an intrinsic, or particularly an intrinsic pulmonary fibrosis. And we see this very specifically. Sometimes, again, we used to call these interstitial lung disease because we used to think the fibrosis primarily only occurred in the interstitial spaces, but we found now it deposits all over the place. It's diffuse. So sometimes instead of calling it interstitial lung disease, you may also see it called diffuse parenchymal lung diseases. So understand that. Now, When we have these diseases, these diffuse parenchymal lung disease or interstitial lung diseases where there's lots of fibrosis of the lung parenchyma, there are so many different causes behind this. And we're going to talk about each one of those below because that's the more in-depth discussion. But what I want to take a quick second to talk about is, remember, the lung tissue is not the only thing that's important for the actual expansion of lungs, to being able to inhale properly, take a good deep breath. That's not the only thing that's involved in a part of our respiratory system being able to breathe. You know what else is involved? The pleura, the pleural cavity. If there's lots of fluid in the pleural cavity, imagine the lung being able to expand against a pleura that's filled and chalked up with fluid. Are you going to be able to expand this lung against a big fluid cavity now? No. So pleural effusions can also act as a restrictive lung disease, but it's not due to a pulmonary tissue issue. It's an extrinsic or extrapulmonary disorder. So pleural effusions, big fluid in the actual pleural cavity, or a lot of air in the pleural cavity like a pneumothorax, that's also going to push on the lung and prevent it from being able to expand. What if the pleura is not a problem? What if it's due to the muscles or the nerves that supply the muscles? You know, your intercostal muscles, your diaphragm, they're supposed to be able to contract and help to be able to bring the diaphragm down, lift the ribs up and outward. And if that doesn't happen, we can't expand the actual lungs, and particularly the chest. And so inflation or inhalation of the actual lungs is going to be impaired. What if there's weakness of the muscles due to the nerves that are supposed to be supplying them being damaged, like in Guillain-Barré syndrome? Or there's inhibition at the actual neuromuscular junction due to antibodies that are attacking the nicotinic receptors like myasthenia gravis. Or what if there's actually damage to the muscles themselves, such as dermatomyositis or polymyositis? That could be another reason. So it could be the pleural cavity that's the problem, could be the muscles that are involved in breathing that's the problem, or what if there's just not a lot of flexibility within the actual chest wall? There's problems with the actual skeletal muscle structure, the skeletal, the bone structure, the ligaments, the joints that are around that. In situations like scoliosis, or ankylosing spondylitis, or what if you have a big chunky fatty layer that's sitting on top of that, preventing the actual chest wall from being able to expand in situations like super obesity. These are big things to think about for patients who have restrictive lung disease. So now, quick understanding, again, lots of fibrosis of the lung tissue causes decreased lung compliance. They don't want to stretch. They don't want to inhale and bring air in as well as normal lungs. This could be intrinsic disorders, meaning it's a part of the lung parenchyma that's actually undergoing fibrosis. There's many that we'll talk about down here, or it's extrinsic. Remember, pleural cavity disorders, neuromuscular disorders, or chest wall disorders. All right, let's talk about the particular causes that we can actually see for intrinsic pulmonary disorders within that restrictive lung category. All right, so now when we talk about these interstitial lung diseases or diffuse parenchymal lung disease, again, this is the intrinsic types of restrictive lung diseases due to fibrosis that is occurring of the bronchioles, the alveoli, the interstitial spaces, the pulmonary capillaries. There's many different diseases that actually fall within that category that lead to that excessive pulmonary fibrosis. Now, when we think about these, one of the categories that I want you to put them in is granulomatous. You know, granulomas, there's different types. There's caseating, which you see in like tuberculosis, and there's non-caseating that you can see in situations of like sarcoidosis and hypersensitivity to pneumonitis. So I want you to group it into this category. One of the intrinsic restrictive disorders that I want you to think about, or interstitial lung disease or diffuse parenchymal lung diseases, is granulomatous diseases like sarcoid, big one to remember, and the second one is hypersensitivity pneumonitis. That's the big pathophys. Now, granulomas are basically, you have this kind of like clump of tissue here, which has you have like a lot of macrophages, then around that you have lymphocytes, and then you have these like things called giant cells, and then lots of fibrous tissue around that. And this kind of tissue, when it gets deposited into the actual bronchioles, the alveoli, the interstitial spaces, around the pulmonary capillaries, it really kind of causes this excessive fibrosis and restricts the lungs from being able to expand. Now, we can see this in sarcoid and hypersensitivity pneumonitis. Both of these, that's the cause, non-caseating granulomas, the deposit in the lung tissue. Big thing that you can think about with epidemiologically between these two disorders whenever they present them in the vignette is that sarcoidosis, we primarily see this in very young African American females, 20s to 30s, and also they may present this as a clinical vignette cue, is exposure in the past to Borrelia burgdorferi, which is the bacteria responsible for Lyme disease, or exposure to Mycobacterium tuberculosis, which is what's responsible for TB. So if they've had some type of exposure to these pathogens in the vignette, young African American female with granulomatous infiltration of the actual pulmonary tissue causing a diffuse parenchymal lung disease, think about sarcoid. If it's a farmer, this is the big one. Think about farmer's lungs. So sometimes we see this in like patients who are actually exposed to lots of spores from the actinomycetes or from certain types of other situations like exposure to hay, barley, some of the organic dust that's in the actual hay, the barley, or the proteins that you may have in pigeon droppings or the feathers from pigeons can actually trigger this granulomatous type of response that you see in patients who have intrinsic lung diseases or these interstitial or diffuse parenchymal lung diseases. So hypersensitivity pneumonitis, think about a farmer, someone who's actually working with hay, barley, or is exposed to a lot of pigeon protein, like the pigeon droppings that have lots of proteins within them that can be inhaled, or the feathers that have lots of these proteins on them. And again, can trigger a granulomatous response. The second category that I want you guys to remember for interstitial lung disease or these diffuse parenchymal lung diseases is a category called pneumoconiosis. So similar to hypersensitivity, there's exposure to an organic dust, if you will. Some type of substance that when it gets into the lungs, it acts as that particular trigger, activates the immune response, causes lots of fibroblasts to cause fibrosis of the lung tissue. What is really important that they're going to present in the vignette is the type of environment that this occupational exposure came in or the particular organic dust that they were exposed to. And it's really critical to think about these. We'll test your knowledge on these a little bit later. But what I want you to remember, if they present in the clinical vignette that you have a patient who's developed this interstitial lung disease and they work as a sandblaster, they work in mines, they work in foundries, which are like metal factories, you really want to be thinking about something called silicosis. If they're talking about a patient who works as a shipbuilder or works in plumbing because they're like fitting different pipes, or they're working in roofing because they're dealing with insulation, this is a high risk category for asbestosis. If the patient is working in some type of aerospace industry, right, where it's exposed to different nasty types of rocket fuel or things like that, or electronics, they're working in maybe computers or ceramics or tool and die manufacturers, you really want to be thinking about a disease called berylliosis. Okay, berylliosis. And then last but not least is if there is a patient who's working in particular coal mines or carbon mines. It has to be very, very specific. Coal or carbon mines, you want to think about what's called coal workers pneumoconiosis. So we call this CWP, coal workers pneumoconiosis. All right, so we got, again, granulomatous diseases, sarcoid, and hypersensitivity. One, think about the farmer working with barley, hay, or pigeon droppings. Then young African-American female with exposure to TB or Lyme's. Then you got pneumoconiosis, you got silicosis, asbestosis, berylliosis, and co-workers pneumoconiosis. The next thing that you want to think about is the patient exposed to particular drugs? So if they present in the clinical scenario, patient has been on methotrexate for some type of underlying immune disorder or some type of like rheumatological disorder, they've been on methotrexate. And they've been on methotrexate for a while. Methotrexate has the ability to trigger this type of fibrosis response, as well as maybe they have AFib and they're being treated with amiodarone. Or they're on nitrofurantoin and they're taking this maybe particularly because they have very frequent urinary tract infections like cystitis. Or they're taking bleomycin as a type of chemotherapeutic agent for some particular reason. These are one of the most common agents to think about. So if they present these drugs in the clinical vignette, they could be the reason that the patient has developed a diffuse parenchymal lung disease, lots of fibrosis of their diffuse parenchymal tissue. So think about these. The next category, so we got granulomatous, we got pneumoconiosis, we got drugs, methotrexate, amiodarone, nitrofurantoin, and again, bleomycin. The next category is collagen vascular diseases. So these are kind of like immune disorders. They're almost like an immune disorder where they actually cause a lot of autoantibodies to be produced. And these autoantibodies may actually cause destruction of some of the actual lung tissue and surrounding maybe pulmonary capillaries. It may cause a little bit of vasculitis of the pulmonary capillaries, but they're going to inflame some of that actual parenchymal tissue. When you inflame the parenchymal tissue, constant repeated lung injury activates fibroblasts that start laying down fibrous tissue. What are these diseases that have autoantibodies that are attacking some of the parenchymal tissue, leading to this fibrosis over time? Well, the first one that you want to think about is there antibodies that are attacking this lung tissue in a disease called scleroderma. Think about anti-SCL70 or anti-centromere antibodies. These could be the ones that are attacking the actual lung tissue and causing fibrosis. If they present in the clinical vignette that the patient has exposed some type of very particular antibody, such as what's called C-ANCA antibodies. C-ANCA antibodies, cytoplasmic, anti-neutrophilic cytoplasmic antibodies that are attacking the actual parenchymal lung tissue, particularly the capillaries, and causing something called granulomatosis polyangiitis. You know what else they call this? Wagner's granulomatosis. The other one is if they have some type of autoantibodies that are destroying the actual lung tissue or the vascular tissue, again, the parenchymal lung tissue, and these are specifically called P-ANCAs. Pericytoplasmic anti-neutrophilic cytoplasmic antibodies, destroying the actual parenchymal lung tissue, causing fibrosis. And lastly, what if they have exposure to a very specific type of antibody, which are going to be attacking the basement membranes around the actual respiratory membrane. So you know the respiratory membrane is the alveolar capillary. You get a thin little basement membrane. Then after that, you have the pulmonary capillaries. These antibodies love to attack the actual basement membrane tissue and cause destruction of that, inflammation, lung injury, repeatedly, and then fibrosis. These antibodies are called anti-GBM, glomerular basement membrane antibodies. And so these are also really important because not only do they attack particularly the antibodies of the glomerular basement membrane, they also attack the basement membrane of the pulmonary system as well, the respiratory membrane. All right, this is the collagen vascular disease. So for diffuse parenchymal lung disease or interstitial lung disease, think about granulomatous diseases, pneumoconiosis, drugs, collagen vascular diseases in one last category. We don't know why they develop it. And this actually happens to be one of the more common ones because sometimes we can't find a particular cause for these patients who have diffuse parenchymal lung disease. We can't find that trigger, that specific reason. And for these, we call this idiopathic pulmonary fibrosis. We have somewhat of a thought as to why these patients may develop this type of fibrosis, and we think it may be due to smoking or old age, but it's more of a hypothetical reason. We don't have a clear-cut idea. So idiopathic pulmonary fibrosis is a diagnosis of exclusion. It's the only one of these that causes the intrinsic or diffuse parenchymal lung disease or interstitial lung disease that's damaging the actual alveolar tissue, bronchial tissue, interstitial lung tissue, pulmonary capillary tissue that we don't have a cause for. That covers the types, the causes, the pathophys. Now we got to do is take these disorders, particularly the one that we're going to focus on for the rest of this lecture, the intrinsic, the diffuse parenchymal lung diseases, the interstitial lung diseases. We're not going to talk too much about the extrinsic or the extrapulmonary causes. We're going to focus on the intrinsic ones now and talk about their features, their complications, how do we diagnose it, and how do we treat it. Let's get there. All right, so when we talk about the features and complications of these diffuse parenchymal lung diseases, interstitial lung diseases, again, all the intrinsic types of restrictive lung diseases. We went over the granulomatous, we went over the pneumoconiosis, we went over the drugs, we also went over the collagen vascular, and then we had the idiopathic one. For the most part, there's a general classical features that you will see in the clinical vignette for all of these. And what they may present with is in the vignette, they'll say that the patient is coming to the clinic or to the hospital and they're presenting with dyspnea, shortness of breath. When you examine them, you'll listen to their lungs, and what you'll listen for is something called bibasilar crackle. So at the basis of their lungs, they're going to have this Velcro-y type of sound. And that's due to having to actually open or popping open those bronchioles and alveoli during inspiration because they're kind of collapsed because of all that fibrosis that's around them. So classic features, they'll come to the clinic with a dry cough, more specifically dyspnea on exam, bibasilar crackles. That's important. You may see from chronic hypoxemia nail clubbing, but it is not pathognomonic or diagnostic of interstitial lung disease. Remember that. Dyspnea, bibasilar crackles, by far the biggest types of things to think about for their history and for the physical exam. Other things to think about is when you take their vitals, you throw that O2 sat on them. What is it going to look like? It depends upon the severity of their interstitial lung disease. If you have a massive amount of fibrosis in the interstitial spaces around the alveoli, in between the actual alveolus and the actual pulmonary capillaries, lots and lots of fibrosis. Look at the distance now that this poor little oxygen has to be able to move to go from the alveolus into the blood. That's a long distance. And whenever you increase the distance, whenever you increase the thickness of the respiratory membranes, all of this is your respiratory membrane. Whenever you increase the thickness of that respiratory membrane, so we're going to increase the thickness of the respiratory membrane, it'll decrease the diffusion of the oxygen. And because of that, not as much oxygen is going to be able to get into the bloodstream. So if you don't have a lot of oxygen inside of the bloodstream, what is this called whenever O2 is low inside of the bloodstream? Hypoxemia. This hypoxemia may trigger a reflexive response. Your brain is going to say, oh, their oxygen's low. They must not be ventilating well. If I have them breathe faster, breathe deeper, maybe they'll bring in more air, more oxygen, and push more into the blood. But that's not the case because that respiratory membrane is going to still remain to be thick. And so it's going to cause this dyspnea and this tachypnea that you'll see in the patient, as well as a low O2 sat on their actual pulse ox. Now, they may also have somewhat of a difficulty being able to exhale CO2 because in the same way, CO2 has to move across this thick respiratory membrane as well. And so there may also be some degree of hypercapnia as well. But I think the big thing to think about is hypoxemia, which causes tachypnea, dyspnea, listen at the bases, bibasilar crackles. These are the classic features. Now, in the same way with obstructive lung disease, this alveoli is fibrotic, this one's fibrotic. Right? If we had a good alveoli, imagine that there's a third one sticking out over here. It's normal, it's healthy, there's not a lot of fibrosis over it. We would have good ventilation going to that one and good perfusion going to this one. Right now there's good ventilation here and there may be good perfusion, but the actual exchange process is the problematic issue. So what happens in these patients with interstitial lung disease, look at this. You have decent ventilation, okay ventilation. I should actually be very careful because, again, they're not going to be taking in as much air as usual. Why? Because of the fibrosis. Because they have significant fibrosis, they can't take in as much volume of air. But on top of that, not only is that the problem, they got this thick respiratory membrane. So the ability to cross the respiratory membrane is the other problem. So that's impaired. So because of this, what the actual pulmonary vessels do is they're very smart. They say, I don't want to send blood flow to these poorly ventilated alveoli or these alveoli that aren't going to give me good exchange. I want to send blood to other alveoli that are getting well ventilated and will have good exchange. And so what happens is they undergo pulmonary artery vasoconstriction. If the pulmonary arteries vasoconstrict, what happens to the pressure in these pulmonary arteries? It increases. So you increase what's called the pulmonary artery pressure. That is going to cause this right heart to go ape crap and start freaking out because it's going to have to get super thick and become hypertrophic to push all that blood that it can into these actual very constricted vessels. And this will eventually lead to right heart failure. And we say that whenever right heart failure is due to an underlying lung disease, like interstitial lung disease, we call that cor pulmonale. Do you guys remember how these patients would present? What would happen if your right heart stopped working? Blood would go up the superior vena cava, cause JVD. Go down the inferior vena cava, cause hepatomegaly, ascites, and pedal edema. So look for that as well in the clinical vignette. We have a basic idea of the general features of these interstitial lung disease, but one of the key things for your actual exam is they're going to try to trip you up and say, okay, which one of these do you think it actually is? Which one of the, do you think it's one of the granulomatous ones? Do you think it's one of the pneumoconiosis? Do you think it's maybe like one of the collagen vascular diseases? And so they'll present very particular types of clinical features that point to one of those. And I want to focus on some of those a little bit now and talk about some of the specific features of these interstitial lung diseases. All right, so we have a patient who comes in on the clinical vignette. They say, okay, they want to determine if this patient has interstitial lung disease, but they want to find the actual cause. So they may present this in the vignette where the patient comes in, they say, okay, I got some dyspnea, they have some bibasilar crackles, they have some hypoxemia, they have some tachypnea, they don't really have any evidence of cor pulmonale yet, but you have a young African-American female, history of tuberculosis, Lyme's disease possibly, and they come in and they have these other additional findings in their vignette. Really think about these. First one, take a look, particularly on their chest x-ray. If you get one, you may see very big hilar lymph nodes. So we call that bilateral hilar lymphadenopathy. The other thing is really take a look at their skin. That's a big one. So look at the cutaneous findings. They may have, for the cutaneous findings, some kind of like violaceous rash within the face. We call this lupus pernio. This is what it looks like. On top of that, they may also have these like nodules that can appear within the skin, especially on the lower extremities, like on the shins. And this is called erythema nodosum. This is what this looks like. On top of that, take a look at their eyes. So not only cutaneous findings, but ocular findings. They may have actually what's called eye pain, ocular pain, and then sometimes some hyperemia of the eyes. And this can be what's called anterior uveitis. This is what this looks like. All right, so we've had our patient come in, we've taken a look at them, we found some cutaneous findings, we found some ocular findings. The other thing to think about is that you have the patient comes in, they're like, oh man, I got some flank pain, abdominal pain, I'm peeing out blood. What's going on with me, doc? The reason that may be is because they may have something called nephrolithiasis. They may have some actual renal calculi, some actual stones. And why that's a problem is because they have lots of calcium that's building up there. And here's the reason why. Those granulomas that you see in sarcoid, those macrophages pop out lots of what's called 1-alpha hydroxylase. You guys remember 1-alpha hydroxylase? It's one of those enzymes that helps to be able to convert what's called 25-hydroxycholecalciferol, which is the inactive form of vitamin D, into the active form of vitamin D. So now we got our stimulated form of vitamin D because of the presence of this enzyme. If this granuloma is pumping this enzyme out, what are we going to do? We're going to increase the amount of active vitamin D. What does vitamin D do? Guess what? Acts on the GIT, increases calcium absorption. If we increase calcium absorption across the GIT, now we have hypercalcemia. Calcium can then go and deposit into different parts of the actual ureter and maybe lead to kidney stones, therefore nephrolithiasis. And they may even have lots of calcium in their urine as well, so hypercalciuria. So look for hypercalcemia, hypercalciuria, nephrolithiasis, and increased vitamin D. All right. The next thing that you want to be thinking about is look for any types of neuropathic findings. So sometimes these granulomas can deposit along the length of a very particular nerve called cranial nerve 7, the facial nerve. And when it deposits along that, it actually decreases the function of the facial nerve. And if the facial nerve, which is supposed to be involved with particularly like facial expressions, is actually diminished, what do you think is going to happen? One side is just going to droop. And you got this poor little guy here. He's got a drooping face. And so there's going to be massive unilateral weakness of the face. So look for facial nerve palsy as a potential implication of sarcoid. The last one is that there could be lots of these granulomatous infiltrations of the actual bundle system. What if I bundle this around the AV node or the bundle branches? I can then lead to like an AV node block, a bundle branch block. And what if I deposited this into the myocardium of the heart? Now I'm going to deposit this kind of like fibrotic tissue into the heart, and now the heart doesn't want to expand and get filled properly. And this can lead to restrictive cardiomyopathy. So look for these particular findings in a sarcoid patient. All right, the next thing. If you think that maybe the patient doesn't have sarcoidosis, you think, okay, what if they have hypersensitivity pneumonitis? Well, I know it's a granulomatous disease. I know it's due to some particular occupational exposure, such as pigeon droppings, such as working with hay, such as working with barley. If they present that in their history as a farmer, and it usually only occurs rapidly whenever they're exposed to that actual occupational exposure, and then guess what? You remove them from that, and all of a sudden, really quickly, within hours, maybe 12 hours, they quickly improve. That is a very characteristic sign of hypersensitivity pneumonitis. So when they're exposed to these particular triggers, they have the exacerbations, they have these findings. You remove them, they have gradual improvement over hours to potentially days. Hypersensitivity pneumonitis. Next one, you think, okay, what if a pneumoconiosis? Maybe it's silicosis, asbestosis, borreliosis, or coal workers. Obviously, think about the actual history. Were they a sandblaster? Were they working in mines? Or were they working in foundries? That would be representative of silicosis. So think about that in their history. On top of that, guess what else silicosis is at high risk of? Tuberculosis. You're like, what the crap? How? You know why? Silicosis actually causes macrophages. You know, whenever macrophage, they eat a particular particle, it's called phagocytosis, they form something called a phagosome. And then that phagosome is supposed to combine with things called lysosomes. And then it makes something called a phagolysosome. It inhibits that. It inhibits this phagolysosome where you're supposed to be able to release these lysosomes to break down this particular bacteria. And guess what? Silica prevents this phagolysosome from forming, and now you can't break down bacteria that are really hardy. And guess what this bacteria is that's really hardy? Tuberculosis. And so because of that, these patients have a very high risk of tuberculosis. So think about that in a silicosis patient. On top of that, if you happen to get a chest x-ray, look for any really heavy calcifications that almost look like eggs of the lymph nodes, particularly around the hilar lymph nodes. All right. The next one is asbestosis. So in asbestosis, obviously the patient will come in, they'll present, oh yeah, I'm a shipbuilder, I work as a plumber, I work as a roofer, and I deal with insulation or pipe fitting. That's obviously within their history. But also, guess what these patients are super high risk for? And that's something that you need to be thinking about. They can have cancer that develops of their actual pleural tissue. So they can develop mesothelioma. Even more fearful than that, they have a very, very high risk, even higher risk than mesothelioma, of what's called bronchogenic carcinoma. So a tumor that can actually develop inside of the airways. And last but not least, the patient also can develop lots of fibrotic plaques, particularly where? At the bases of the lungs. So silicosis, borreliosis, co-worker's lung, guess what they particularly prefer to attack? The upper parts of the lungs. They have an upper lobe predilection. Guess which is the only one that has a lower lobe predilection? The asbestosis. Okay, so we've got sarcoid, hypersensitivity, and some of the pneumoconiosis. Let's now move on to the next component, which is some of those collagen vascular diseases. All right, so the next one that I want you guys to think about is, okay, what if the patient has a collagen vascular disease? Obviously, drugs are pretty easy. You just look at the patient's history. So think about those drugs in their medical history. Have they taken any kind of amiodarone, any nitrofurantoin, any methotrexate, any bleomycin? That's obviously things to look at in the history. But then when you talk about collagen vascular disease, there's maybe particular clinical features that points out to one over the other. In scleroderma, there's this classic way that we can remember them via what's called the CREST. Now, this isn't all patients. It could be like a limited systemic sclerosis, but in these patients, you can remember CREST, calcinosis, so hard calcium deposits of the actual skin. It actually is really interesting. It looks like this. The other one that I want you guys to remember is sometimes they can have what's called Raynaud's phenomenon. So they can have kind of like a vasospasm of the vessels near their actual digits. It can cause them to present in different colors. It actually looks like this. The other thing that I want you to remember is, so we have CR, CREST, CR, esophageal dysmotility for the E. So they can actually present with maybe some difficulty in being able to swallow, so some dysphagia, maybe even some chest pain because of a lot of the actual dysmotility there. And then the next one is sclerodactyly. So sclerodactyly is actually a very interesting one. It's where they actually have like there's so much fibrosis of their skin around their fingers that actually kind of turns on to like a claw-like look. And so this is what sclerodactyly actually looks like. The last one that I want you guys to remember, that they can actually have like these vessels on the superficial aspect of the skin that can actually appear dilated, and this is called telangiectasia. And so I want you to take a look at what this looks like. All right, so we have an idea now of how scleroderma patients may present a little bit differently in comparison to others. The next one is, how do we know about these other ones, like granulomatosis of polyangiitis, also known as Wegener's, eosinophilic polyangiitis, also known as Churg-Strauss, and then the last one, which is called Goodpasture syndrome, which is a really cool one. But granulomatosis or Wegener's, one of the big things is that pretty much all of these, granulomatosis, eosinophilic, and Goodpastures all present with glomerulonephritis. So they may present with some type of hematuria, proteinuria in that sense. One of the big differences, though, is that when patients have Wegener's or granulomatosis, they present with a chronic rhinosinusitis. So look for that as a potential feature. Sometimes it can even eat away at the tissue at the nose and cause like a saddle nose deformity. The other one is for eosinophilic. Look for them to have a history of asthma or some type of allergic rhinitis or allergic sinusitis. The last thing that I want you to think about is for Goodpasture syndrome. They may also have a glomerulonephritis, but look in their history to have a history potentially of hemoptysis, so coughing up of blood. That is the big ways that we can differentiate some of these other type of collagen vascular diseases. And what about idiopathic? We don't have a particular reason, and they're going to present classically as though the general features, which is the dyspnea, the tachypnea, the hypoxemia, the bibasilar crackles, maybe potentially some nail clubbing, and again, later stages of the disease, cor pulmonale with JVD, hepatomegaly, ascites, and pedal edema. I hope this really gives us a good understanding of how to separate some of these particular etiologies of interstitial lung disease or diffuse parenchymal lung disease, because now we got to move on to how do we diagnose these bad boys. All right, so now we're going to talk about the diagnosis of restrictive lung disease, but one of the most important aspects of this is really understanding pulmonary function tests. Let's watch this clip that we talked about in obstructive lung diseases, going over pulmonary function tests, and really help you guys to just recall that, remember that, and go back over it again. Let's go and take a look at that. All right, so first thing when we talk about pulmonary function tests, we're going to do some things called spirometry. And what we're going to try to determine is we're going to look at a couple different parameters. When we take a patient who has normal lungs in comparison to obstructed lungs versus restricted lungs, we're going to look at three particular things with the pulmonary function test. What I want you to understand is when a patient is breathing, okay, they have normal, healthy lungs. When they're breathing normally, normal, quiet breathing, taking a breath in, taking a breath out. That normal quiet breathing is this purple kind of line that's oscillating here. That's called your tidal volume. Now, whenever a patient decides to take a deep breath in beyond their normal tidal volume inhalation, so that's called their inspiratory reserve volume. So it's the amount of air that they can forcefully inspire beyond their tidal volume inhalation. That's the IRV. The next one is the amount of air that you can forcefully exhale beyond your tidal volume exhalation. That would be your ERV. So I'm gonna look a little dumb here, but go. That amount of air that I blew out beyond my tidal volume exhalation is called my expiratory reserve volume. The amount of air that remains in my lungs at the end of that forced exhalation is called the residual volume. That's the amount of air that kind of keeps the alveoli open and prevents them from collapsing. And that's an important concept. And what I'm going to do is we're going to take and look at this graph and compare it. What happens to the IRV, the TV, the ERV, and the residual volume in obstructed and restricted lungs? But before we do that, we have to talk about one more thing. There's another terminology which you guys see here called forced vital capacity and total lung capacity. What I want you to remember is that forced vital capacity, FVC, is the combination of your inspiratory reserve volume plus your tidal volume plus your expiratory reserve volume. This is called your forced vital capacity. Your total lung capacity is your forced vital capacity plus your residual volume. So if I go all the way from here down to my residual volume, this is called my total lung capacity. What I want us to now understand is what happens to all of these volumes in a patient who has obstructed lungs versus restricted lungs. Let's take a look here. So in a patient who has an obstructed lung disorder, what is the classical feature, whether it's asthma, whether it's COPD, whether it's bronchiectasis? There's a problem being able to get air out. So because of that, air stays trapped in the lungs. They hyperinflate. They're big old chunky lungs. Because they're big, compliant, very large lungs, what would we expect? We would expect that they're gonna have really big, chunky lungs. Now here's what I want you to think about. If a patient has really, really big lungs, imagine how hard it would be to take in, so imagine my lungs are already filled here, right? And I'm gonna try to take a deep breath in beyond my normal tidal volume. How hard is that gonna be to take in a large volume of air when my lungs are already hyperinflated? Imagine the lungs being already filled almost, and you gotta try to take in a lot of air. It's not gonna happen. So in these patients, their inspiratory reserve volume, the amount of air that they can forcefully inhale beyond their tidal volume inhalation, is very low. So that is reduced in patients who have obstructive lung diseases because you can't take in a large volume of air because they're already super puffy and inflated. Their tidal volume actually doesn't become affected though, thankfully, right? So that's relatively normal. The amount of air that they can breathe in during normal inhalation and exhalation is the same. Their expiratory reserve volume, the amount of air that they have available that they could forcefully exhale after the tidal volume exhalation, is insane. Because look how puffy these dang's lungs are. They're huge. And so because of that, their expiratory reserve volume is increased, and their residual volume, the amount of air that they have remaining in the lungs after exhalation, is also increased. They're air trapping. So they have a very high residual volume. We sometimes use a very special term here, which I want to write down here for a second. It's called functional residual capacity. So the functional residual capacity, FRC, is elevated in patients who have obstructive lung diseases. Okay, now, let's use this concept of what forced vital capacity is and what total lung capacity is then, right? In patients of obstructive lungs, their lungs are hyperinflated. So the amount of air that they have available to be able to exhale is large. The amount of air that they have sitting in their lungs after they exhale, forcefully exhale, is large. So their functional residual capacity is large. The amount of air that they can try to bring in forcefully is very little because their lungs are already hyperinflated. Think about how much air their lungs can occupy at an entire time. So total lung capacity is the IRV plus the TV plus the ERV plus the RV. In this situation, my RV is massively increased, my ERV is increased, my tidal volume stays the same, my inspiratory reserve volume will reduce a little bit. If that's the case, this is actually going to cause the lungs to have a very, very large total lung capacity. The total lung capacity for obstructive lungs is increased significantly. okay? And that is in part due to these two factors. The ERV and the RV significantly increase. Just to put it in perspective, let's give it a double arrow. Let's give this a double arrow here, and let's give this a double arrow here, okay? And therefore the functional residual capacity is going to increase. Okay, the forced vital capacity is the IRV plus the TV plus the ERV. Well, the ERV is increased, the IRV decreases. So the FVC may decrease, but it almost may be normal. So sometimes in these patients, it can vary from where it can actually be relatively normal to mildly decreased. It can be normal to mildly decreased. Usually in the early stages of obstructive lung disease, it's relatively normal. As they get later and later and later into the disease, their FVC starts to decrease. So that's what I want you guys to remember. Their FVC may be relatively normal in the early stages and decrease as we get to the later stages, okay? That's this component here for obstructive lungs. Now let's go to the restrictive lungs. For the restrictive lungs, look at the size. Oh my gosh. Big old suckers, baby suckers, right? In restrictive lung disease, we haven't talked about this yet, but in their situation, they're very, very fibrotic. They're super, super kind of like elastic, and they just don't want to be able to expand, and they just want to collapse naturally. They just don't want to be able to bring air in, and they collapse really easily. So it's really hard to fill these lungs. And they don't have a lot of air in them. They're very, very tiny. So because of that, imagine this. How hard is it going to be able to bring air into these stiff, non-compliant lungs? Very difficult. So being able to forcefully inhale a ton of air, do you think I'll be doing a good job at that? No. So these patients' IRV is reduced. Tidal volume doesn't really change, thank goodness. That's relatively straightforward. The amount of air that they can bring in normally during quiet breathing and out during quiet breathing is the same. Their ERV, look how little their lungs are. They don't have a lot of air that are available for them to exhale. So because of that, their ERV is reduced. And then the residual volume, the amount of air that they'll have remaining in their lungs at the end of a forced exhalation, is also really little. So there's a residual volume will be reduced. And the combination of these two, which is called our functional residual capacity, will be reduced. If we take all of this into consideration and look now at the total lung capacity, which is all of these things added up, there's a lot of down arrows, my friends. So what do I expect to happen to the total lung capacity if I added all of these up? I expect it to be low. So I'm going to have a very low total lung capacity. Forced vital capacity is the IRV plus the TV plus the ERV. Two down arrows and one's kind of normal. I expect the actual FVC to be low. And so in this situation, I want you to remember that the FVC is really, this is why I want you to stress this. FVC is really low in patients with restrictive lung diseases. In obstructive lung disease, it can be normal to slightly decreased. Okay, that's one of the big features to understand here. Now, we've had a basic concept of these numbers whenever we're having a patient breathe into what's called a spirometer. So basically, all of these things, we're taking a patient who has normal lungs, obstructive lungs, restrictive lungs, having them breathe into this spirometer apparatus and then give us all of these particular things and help us to be able to kind of determine, based upon these volumes, where they kind of fall within the obstructive versus restrictive versus normal lungs. We can further extrapolate this. And really what happens when we do these spirometer devices, we actually get these things called flow volume loops. So what this is going to show us here is on the x-axis here, we're going to have volume. On the y-axis, we're going to look at the flow of air. On the top part, it's going to be expiration. On the bottom part, it's going to be inspiration. Okay? And then here's 0 liters, 2 liters, 4 liters, 6 liters, 8 liters. So when a patient takes a breath in, normal lungs, they're going to inhale. When they inhale, they're going to potentially inhale beyond what they already have in their lungs. So here, this patient's going to start taking in air, and it's going to go from 2 liters during their inspiratory process to about 7 liters during their inspiratory process. Then during expiration, they're going to have a normal flow outwards, and then again, that'll start to decrease and take them back to their original volume. Okay? Now, what this gives us is kind of a couple different things. From this point here, from the moment of inspiration all the way here, expiration all the way here. This is going to continue. Think about this. I take a deep breath in beyond my tidal volume inhalation. This would be my IRV. And then I take and I breathe out as much air as I forcefully can during exhalation. This would be my ERV. And then the volumes that are actually just going to be during the normal quiet breathing process, my tidal volume. So my tidal volume plus my IRV plus my ERV is my forced vital capacity, right? IRV plus TV plus ERV is forced vital capacity. So from this point here to this point here is what's called my forced vital capacity. The amount of air that remains in the lungs after I've exhaled all the air that I possibly can is what? My residual volume. And then if I were to take the residual volume plus the forced vital capacity, what would this be? This would be my total lung capacity, this entire thing here. This is for normal lungs. So what I want us to do now is imagine this is what the normal flow volume loop will look like in normal healthy lungs. If I have a patient who has obstructive lungs, what do I know? What do I know about these particular parameters in a patient who has obstructed lungs? Well, they're hyperinflated. If they're hyperinflated, they're going to have a high residual volume. We know that if they have a high residual volume, what's that going to do? What we know is an increase in residual volume plus an increase in their expiratory reserve volume plus a normal tidal volume and a mild decrease in their IRV causes their total lung capacity to increase. And we said that their forced vital capacity, which is their IRV plus their TRV plus their ERV, can do what? It can be somewhat normal to slightly decreased. So if I were to kind of do this, it would be here to here, okay? So somewhere between normal to slightly decreased. What would that look like in comparison to the normal graph, which is here in black? Well, now, I would expect my forced vital capacity to be what? Potentially the same, but I would expect my residual volume to be increased. So what I'm going to do is, look where my graph starts here now. I'm going to take a deep breath in beyond my normal tidal volume inhalation, and then I'm going to exhale as much as I possibly can during exhalation beyond the tidal volume exhalation. So this is going to be my entire forced vital capacity. So from here to here is my forced vital capacity. If I think about that one in comparison to that one, it might be normal to almost slightly decreased in comparison to normal. But here's the big thing. The amount of air that remains in the lungs after that forced exhalation is called what? My residual volume. So my residual volume is what in this diagram? It's super increased. Because my residual volume increases, it shifts the actual curve of this graph to the left. That's an important thing to be able to remember. So when you're given a graph on your exam and comparing to say, which one of these do you think this lung disease is, based upon the flow volume loop? Is it obstructive or restrictive? If the graph is shifted to the left in comparison to the normal lungs, it's an obstructive lung disease. And in these situations, due to a massive increase in their residual volume, and what will happen to their total lung capacity? Look at this. Look at this son of a gun. It's gargantuous. They have a massive total lung capacity that's increased. And on top of that, you know what else is really cool about these patients? Look for this as well. Sometimes in these patients who have obstructive lung disease, they have this little like coving that you can see sometimes within their graph. And that's because they have a kind of a reduction in their peak expiratory flow rate. And so sometimes you'll see this kind of reduction, this little coving in thing, and that's an important thing to be able to differentiate between obstructive and restrictive. So if you see the curve shifted to the left, with a very massive increase in residual volume and an increase in total lung capacity, you're looking at obstructive lung disease. Now, compare that to restrictive. For restrictive, here's again our normal in black, and in blue, we're going to talk about restrictive. In this situation, what do we know about their volumes? We know their residual volume is decreased. We know that all of these are decreased, so therefore their total lung capacity is decreased. And we know their IRV and their ERV is decreased, and the tidal volume stays the same. But since both of these are decreased, we see their forced vital capacity decreases. Okay? Look at their curve. If I take a deep breath in with this blue line here, a deep breath in beyond normal tidal volume inhalation, and then I breathe out as much air as I can forcefully beyond tidal volume exhalation, then from here to here, from this point here to this point here is my forced vital capacity. So from here to here, this is my forced vital capacity. Look how small that son of a gun is in comparison to obstructive versus normal. That's a tiny forced vital capacity. And then look at this. Look how much, like I might even overshot it. I might have to go kind of go like right here. From here to here is their residual volume, the amount of air that remains in their lungs After a forced exhalation, look at that. That's their tiny little residual volume. And then look, if I take the forced vital capacity and the residual volume and combine them, this is the total lung capacity. Look how tiny it is. So in a patient who has restrictive lung disease, if they show you the graph, what will you see the curve do? You'll see that the restrictive curve will shift to the right. So restrictive, the curve shifts to the right. Obstructive, the curve shifts to the left and maybe has a little coving in of the expiratory curve. That's what I want you to remember. The last thing that we have to talk about here. When you look at these graphs, the next thing that we can do is we can take and look at whenever they're forcefully taking in air and pushing out air. What we can do is we can look at very specifically the volume of air that they are exhaling. So they take a deep breath in. From the moment I begin exhaling until the moment that I stop exhaling, I'm going to monitor that volume. And that's going to be on the y-axis. On the x-axis is going to be the time that it takes for me to start exhaling until I stop exhaling. What I want to know is, what is the maximum volume of air that I can actually exhale during that entire breathing process? The maximum amount of air, which is at the peak point of the y. So on the y-axis, wherever I hit the top, the peak point, that is my forced vital capacity. That would be this point here, okay? At 1 second, let's say that somehow I breathed for, I don't know, 5 seconds. Okay, so during that 5 second period, that was the maximum volume that I could actually reach. That was my forced vital capacity. At 1 second in the expiration process, I want to know how much air I was able to forcefully exhale. We call this the forced expiratory volume of 1 second. What you need to be able to take from this, my friends, is this ratio where we actually say FEV1 over the FVC. This is a particular ratio that we're going to use. In this example, let's say that the amount of air that I could forcefully exhale in the first second was 4 liters. Then that's going to be 4 liters divided by the maximum amount of air that I could forcefully exhale throughout the entire time period. And let's say that that kind of curve goes around 5 liters-ish. So 5 liters. 4 divided by 5 is going to be about 0.8. Multiply that by 100, and I'm going to get 80%. That's about what the normal ratio is between FEV1 and FVC. What I need to be able to determine now is what would that look like in an obstructive and what would that look like in a restrictive lung disease. Let's take a look. In obstructive lung disease, what we notice here is in this red curve here is that the FVC can be reduced. There could be a reduction in FVC. We said that. It could be anywhere from normal to decreased. Okay, so we see that that is potentially reduced a little bit. So let's actually put a down arrow for the FVC. The FEV1 though, that's the worst situation here. Look at their FEV1 in comparison to this one. So here's their FEV1. Let's just kind of, I'm going to make up numbers. I'm going to say that in the normal patient, it was about 4 liters. In this patient, oh my gosh, this is terrible actually. This might be somewhere around like 2. So now this patient's FEV1 is approximately somewhere around 2 liters. What in the heck happened? I dropped their FEV1 significantly. So in patients who have obstructive lung diseases, their forced expiratory volume in 1 second is significantly reduced, whereas their FVC can be just normal to almost slightly reduced. If that's the case and I take into consideration this ratio, what will I get in comparison to 80%? If a normal FEV1 to FVC ratio was 4 over 5 liters, which was 80%, and I went from 2 and I dropped my FVC down, let's just say to 4 liters, I'm definitely going to be less than 80%. If that was the norm, if the norm was 80%, you can tell me that 2 liters and 4 liters, what would that give me? That would give me like 50%. So my FEV1 over FVC ratio was definitely less than 80%. That's what we see in obstructive lung diseases. Important to remember that. Very reduced FEV1 and mildly reduced or normal FVC. All right, so now let's talk about restrictive. Now, it's very interesting here, right? So again, we're gonna take the normal curve here. That's their FEV1 at 1 second. That's their forced vital capacity, right, for the normal patient. Now here's the patient who has a restricted lungs. Look what happens to their FEV1. It drops, but not a crazy amount, right? In comparison to the patient who has the normal one, or in comparison, look at this. Look at the FEV1 here for the restricted and the obstructed lungs. Massive difference, right? So restrictive, not a crazy reduction in their FEV1. We'll just give it like 1 arrow down, okay? Their FVC though, does actually reduce. And so in comparison here was about 5 liters. If I'm kind of like, this is about 4 liters, because that was their FEV1, that was about 4 liters. Here their FVC is about 5 liters. I'm gonna say it's like somewhere around like 3.5. All right, so I'm just kind of extrapolating. So their FVC definitely dropped, maybe like about 3.5 liters. And their FEV1, it's just mildly dropping even a little bit below that one. So let's just like extrapolate that to about 3 liters. If that's the case, their FVC definitely was the one that dropped. Remember, what did I tell you was the big factor here for the restrictive lung diseases? What happens with their FVC? Drops pretty significantly. So what I'm gonna do is, I'm gonna drop my FVC by 2 arrows, and obstructive, I drop my FEV1 by these multiple arrows. So now, if I were to just kind of extrapolate here that I had 3 divided by 3.5, that's definitely gonna be greater than 80%, or at least about same, close to it. So maybe about like 80, 86%. So in that situation here, what do I notice about my ratio? If I look here and my numerator is really small, but my denominator is even really small, what happens to the overall number? It's gonna be large because my denominator is really small. And so in this situation, theirs will be greater than or equal to 80%. So in patients who have normal lungs, what was theirs? About 80%. And the patient who has a restrictive lung disease, theirs is about greater than or equal to 80%. But for a patient who has obstructive lung diseases, theirs is less than 80%. Very important to be able to remember that. And the reason why theirs is less than 80% is because their FEV1 at 1 second is significantly reduced and their FVC is only mildly reduced or almost normal. And a patient who has restrictive lung disease, they have a mild decrease in their FEV1 at 1 second, but their FVC is the one that really drops. So their denominator drops. Even though both of them drop, their denominator drops even more, which allows for their overall number to still be high, at least greater than or equal to 80%. That's what I need you to remember about normal versus obstructive versus restrictive when it comes to the spirometry. To put this in a quick little algorithm, let's come down and talk about that. All right, so when we compare obstructive versus restrictive, we're looking at this ratio that we just talked about, the FEV at 1 second over the FVC. For a patient who has obstructive, what did we just say? Their FEV1 is very low. We know that. So because they have a very low FEV1 and a really mildly decreased or almost normal FVC, what do we expect the ratio to be? Less than 80%. So because of that, they'll be less than 80%. They'll have a decreased ratio. And a patient who has restrictive lung disease, which is the primary problematic issue here. Which one is it, FEV1 or FVC? The FVC is the primary one that's actually reduced. If the denominator is small and the numerator is only mildly small, what's going to happen to the overall number? It's going to be large. So theirs will be greater than or at least equal to 80%. That is the big differences. So when you're looking at a patient and you're given, here's their FEV1, here's their FVC, determine their ratio. If it's less than 80%, this is likely obstructive. And again, the primary problem with this is which one of those actual variables? The FEV of 1 second. Versus restrictive, their primary problematic issue that causes them to be greater than or equal to 80% is they have a very low FVC. All right, great. Now that we've talked about that, there's a couple other things that we can do. All right, so we've gone over PFTs now. Now the next thing that we have to understand for restrictive lung diseases is the DLCO, that diffusion capacity of carbon monoxide. It's really important, and one of the reasons why is it really helps you to differentiate, is this an intrinsic or an actual pulmonary interstitial lung disease, diffuse parenchymal lung disease, or is it an extrinsic, an extrapulmonary cause? Meaning, is it a pleural effusion, pneumothorax, neuromuscular disorder like myasthenia, Guillain-Barré, dermatomyositis, polymyositis, scoliosis, obesity, or angst-Bond. If it's one of those, we'll be able to have somewhat of differentiation between these. Now, one of the ways we can do this is looking at the DLCO. Now with DLCO, it obviously, if you guys remember the formula that we talked about in obstructive lung disease, it's directly proportional to the total surface area. This is a coefficient, and then the pressure gradient. And then it's inversely proportional to the thickness of the respiratory membrane. What is the classical feature of interstitial lung diseases or diffuse parenchymal lung diseases? They have a increased thickness of their respiratory membrane. So what does that do to the DLCO? It decreases the DLCO. So for intrinsic disease, they have a decreased DLCO. But for extrinsic, it has nothing to do with the respiratory membrane. There's no effect. There's no change in the surface area. There's no change in the pressure gradient. There's no change in the thickness at all with respect to the extrinsic, because it's a problem with the pleural tissue. It's a problem with the actual bones or the neuromuscular junction. In that situation, there is no effect on DLCO. So therefore, it should be normal. So a normal DLCO would be characteristic of an extrinsic cause. This is very helpful whenever you're trying to be able to differentiate and weed out between what we talked about as intrinsic versus the extrinsic cause. All right. After we've done the DLCO, the next thing that I want you guys to understand is we can actually take a look at a lot of images. There's a lot of different imaging that we can actually do to help us to differentiate interstitial lung diseases, not just being able to diagnose them, but also maybe specific interstitial lung diseases have a predilection for particular parts of the lungs. Remember I told you, let's see if you guys remember, for the upper lobe, it's mainly going to be silicosis, berylliosis, and co-workers pneumoconiosis. For the bases of the lungs where it caused lots of fibrosis, it would be where? It'd be specifically asbestosis. And remember, the bilateral mediastinal lymphadenopathy is bilateral hilar lymphadenopathy is very common in sarcoidosis. We said, again, for silicosis, they have a lot of the eggshell calcifications of their lymph nodes. So again, some of those classic features are very important when we're talking about these. So let's take a look at some images that are very characteristic and important in patients with interstitial lung diseases. All right, guys, let's take a look here at some images. We have a patient, or particularly a chest x-ray of a patient who has some type of underlying restrictive lung disease. Now, what I told you guys, in patients who have restrictive lung disease, it's a very characteristic type of pattern. There may be some mild differentiation that we talked about between upper lobe predominance, lower lobe predominance, and maybe some things like hilar adenopathy and eggshell calcified lymph nodes, all those things that we talked about with specific characteristics. But the general classification of patients who have interstitial lung disease, they look like this. If you look here, they have all of these like reticular types of opacity, so white opacified types of lines that are moving from the central part out towards the periphery. And then sometimes you may even notice like a nodularity to it. So we call this reticulonodular opacifications. And this is one of the very obvious, very common findings of patients who have interstitial lung disease. Sometimes they also give this what's called a ground glass appearance, which you have to be careful nowadays because obviously we take ground glass and immediately say COVID. But again, this is a very common finding that you'll see in interstitial lung disease, that reticular nodular opacification or ground glass opacification on chest x-ray. Very classic of interstitial lung disease. Let's take a look at another image. All right, so here's another really interesting image. We have a CT scan, so right hemidiaphragm, left hemidiaphragm. Here's the heart, here's the vertebrae. Now what you see here is we see this thing, this is a honeycomb type of sign. We see this very commonly in patients who have interstitial lung disease. Very characteristics of something called, what we called about idiopathic pulmonary fibrosis. So what you can potentially see as we get towards the periphery of the lungs, if you really look, is you'll see somewhat of a honeycomb type of appearance here in the periphery. In some of these areas, you may see this honeycomb type of appearance. Very common, very characteristics of interstitial lung disease, but more specifically, if you see this on a clinical vignette, you see honeycombing of their chest CT. Think about idiopathic pulmonary fibrosis. It's definitely going to be one of those pathognomonic terms to remember. But again, honeycombing definitely very common due to a lot of fibrosis, thickening of the interstitium, and again, this is basically going to kind of give that honeycomb type of appearance. All right, that covers this one. One more image. All right, so the last image here is very interesting, so we can see some of the particular findings that we've already discussed. So again, right hemidiaphragm, left hemidiaphragm. If you look towards the edges, you do see, again, more of that honeycombing type of look, which is very classic in patients who have what's called interstitial lung disease, especially idiopathic pulmonary fibrosis. But one more finding that you want to be potentially aware of, especially in interstitial lung diseases, and sometimes due to that excessive fibrosis, it can create these like potentially like dilate, it causes what leads to what's called traction bronchiectasis, which can really open up some of these bronchioles. So here you see some traction bronchiectasis, and here you see some traction bronchiectasis. This is not the same thing as the bronchiectasis that we saw in obstructive lung disease. That's due to a lot of that mucus secretions. This is usually seen secondary to interstitial lung diseases. So remember that. So you'll see the honeycombing type of look, and you may see this traction bronchiectasis as well in interstitial lung diseases. All right, that covers the images. Let's get back to the whiteboard and talk more about some diagnostics. So we've taken a look at that. The next thing that I want you guys to understand is, okay, we have a pretty good idea that this patient has restrictive lung disease based upon their PFTs. We were able to differentiate if it was an extrinsic versus an intrinsic type of restrictive lung disease off the DLCO. We were able to get a good idea of what maybe an interstitial lung disease off a chest x-ray or a CT scan, and maybe even help us to differentiate which types of pneumoconiosis it could be. The next thing is, what if I think it's an actual granulomatous disease? So I look at their chest x-ray or their CT and I see a little bilateral hilar lymphadenopathy. I see some of the classical features. How do I determine if it's sarcoid? Well, remember some of those things that we said that can happen because of the granuloma releasing lots of what's called 1-alpha hydroxylase. What did that do? Remember, it increased your 1-alpha hydroxylase, which led to an increase in vitamin D. So what would I expect an increase in? I would expect an increase in the vitamin D levels within the blood. The other thing I would see is that basically whenever there was an increase in the vitamin D, that increased the amounts of calcium absorption. So calcium levels within the blood would be elevated. And on top of that, we didn't mention this one, but this one's really actually pretty cool. Granulomas, these granulomas can actually release lots of what's called angiotensin converting enzyme, which is a very odd thing, but it actually will have very increased or elevated ACE levels. So these are things to think about for sarcoidosis. Check the calcium, check the vitamin D, and check the ACE levels. The other thing is that we can go down and do a bronchoscopy and lavage out some of the actual pulmonary fluids. And if this is a patient who has sarcoid, they're going to have lots of lymphocytes. And it's very important to be able to kind of determine the predominance of which type of lymphocyte they have. So what we do is we take and we determine how many CD4 lymphocytes they have and how many CD8 lymphocytes they have. And if the ratio is really particularly an increased CD4 to CD8 ratio whenever we do that bronchoalveolar lavage, that's very characteristic of sarcoid. The other thing is we can actually biopsy an area that we see. So maybe we see this area of fibrosis or granulomatous disease, we biopsy that, and guess what we'll find? Non-caseating granulomas. What other disease, if we biopsied it, and a patient who's maybe exposed to hay or barley or pigeon droppings will also have non-caseating granulomas? Hypersensitivity pneumonitis. Think about that as well. All right. Beautiful. For silicosis, if I think a patient has silicosis, I look at their chest x-ray or their CT scan, I see a lot of eggshell calcifications of their lymph nodes. I know their history. I also potentially have a very strong suspicion that this is silicosis. What could I do? I could actually biopsy those lymph nodes. And guess what I'll find? A lot of silica crystals. And we call that birefringent silica crystals that we'll pick up off that lymph node biopsy. Lots of silica gets deposited there and creates these immune reactions that leads to the eggshell calcifications of the lymph nodes. So we'll biopsy that. The other thing is going to be moving on to the other aspects of the pneumoconiosis. So now we're going to talk about asbestosis, borreliosis, and then we'll talk more about some collagen vascular diseases. All right, so another thing is, what do we think this patient has asbestosis? They have mesothelioma, bronchogenic carcinoma, they got some pleural plaques at the bases of their lungs, right? We look at their history, they have some roof building, some plumbing, some roofing, insulation, shipbuilding, things of that nature. And we're definitely concerned that they have asbestosis. What is another way that we can actually confirm this? Well, we can potentially go ahead and take a sputum sample. And from that sputum sample, we may be able to find a lot of like these asbestos molecules. And when we look at them under the microscope, this is a key term that you may actually see on the exam, is when they look at the sputum sample under the microscope, they see these like dumbbell appearing things called ferruginous bodies. So ferruginous bodies is an important term to be able to kind of correlate with asbestosis as a potential cause of the interstitial lung disease. The next thing is borreliosis. So how do I know about this one? Again, more upper lobe predilection. History. Physical exam is the big things. But for this patient, what I could do is I could also do a bronchoalveolar lavage. Take some of their pulmonary fluid. From that pulmonary fluid, I'll pull out some lymphocytes. I'm going to put that into like a little dish. And then what I'm going to do is I'm going to expose that dish of pulmonary fluid and lymphocytes to beryllium. If in that situation, the lymphocytes start increasing in number and populating and populating and populating, this is an abnormal finding and consistent with borreliosis. So we call this kind of a beryllium challenge test. A beryllium lymphocyte proliferation test is really what it is. We take bronchoalveolar fluid with lymphocytes, expose it to beryllium, and if that in exposure to beryllium, those lymphocytes start proliferating like crazy, it is a positive beryllium lymphocyte proliferation test. It's potentially suggestive of borreliosis. All right, we're almost there. Now, we have some degree, based upon their physical exam findings or their clinical features, their history, this patient's, maybe all of them have glomerulonephritis. This one has the CREST syndrome. This one has what? Asthma, allergic rhinitis. This one has particularly a chronic sinusitis. This one has hemoptysis in combination with a lot of the other things. If this happens, what we can do is we can send off a panel of like these antibodies. And if I think that it's scleroderma, what would it come back as? Positive anti-SCL70 or positive anti-centromere antibodies. If I sent it off and I was concerned that they have Wegener's, what would it come back as? A positive C-ANCA. It'd be positive C-ANCA antibodies. If I was concerned that it was some type of Churg-Strauss or eosinophilic polyangiitis, it would come back as a positive P-ANCA. We're just testing you guys' knowledge here. And then lastly, if I thought it was Goodpasture syndrome, it would come back positive as anti-GBM antibodies. So these are the different things that I can go ahead and test for when I'm potentially concerned that they may have one of these types of collagen vascular diseases. Also, look at their medical list. Look at the potential drugs that they've had. If there's any of those exposures of drugs, that would also lead you to particularly which type of etiology was responsible for this interstitial lung disease. All right, my friends, on to the treatment. All right, so last but not least, the treatment of restrictive lung diseases. Be thankful. There's not a lot because unfortunately these diseases, sometimes the damage has already been done. It's too late to reverse it, or to be honest with you, it's really just this top part here. Treat the underlying cause or just remove the actual trigger. So if the patient is exposed to very particular environmental agents like pigeon droppings or hay or barley, and that's their trigger, get rid of it. If it's exposure to an occupational type of dust, again, an organic dust like silica or beryllium or asbestos, or if it's a coal workers, kind of like a coal mine or carbon mines, get rid of those things, avoid those things. If it's a drug, discontinue it. Stay away from that drug. If it's a collagen vascular disease, it's a little bit different. You can't unfortunately just remove those things, but you can try to treat the underlying disease. And again, if it's idiopathic, we don't really know why. So unfortunately, there's again nothing that we can do for that. But if you can try to treat the underlying disease or remove the particular trigger, that would be the best situation. Oftentimes though, it's just supportive care. So if the patient already has this interstitial lung disease, the damage has already been done, we're just trying to be able to help them to have a better quality of life. And the way that we can do that is kind of perform pulmonary rehabilitation, get them lungs strong, man. Give them particular ways that we can kind of push their ability to work those lungs and get them a little bit stronger and have a better conditioning. The other thing is if the patient has underlying hypoxemia, guess what we can do? Give them oxygen. You guys remember what it was for obstructive? Let's see if I can test your knowledge. But the basic one is if it was at rest, exercise, anything like that, they didn't have an underlying cor pulmonale or polycythemia, what was the SpO2 goal? Less than 88%. And then if we checked the PaO2 via ABG, it was less than 55 millimeters of mercury. But if we had the patient who had cor pulmonale or polycythemia, what could we do? We could check and say, oh, we'll be a little bit more acceptable at less than 90% SpO2, or a PaO2 of less than 60 millimeters of mercury we'd be more accepting of. So that's an important thing to think about for oxygen supplementation in these patients. And last but not least, you know what else is really actually kind of beneficial? Avoiding particular infections. These patients' lungs are already damaged. You can actually cause worsening damage if you have them become exposed to infections. And one of the most common infections that you want to be able to prevent these patients from having is the common ones, so Streptococcus pneumonia. So having these patients get their pneumococcal vaccine is going to be very, very critical. And then on top of that, having them get their influenza vaccine, because we know that influenza is another type of viral agent that can definitely cause injury to the lungs, and especially in elderly, increase their exposure or risk of Staphylococcus aureus pneumonia. So good infection control is also going to be key in these patients. The next thing to think about is, what if I can't treat the underlying cause? I can't remove the exposure or get rid of the trigger. I provide supportive care actively, but a patient has an inflammatory cause, like a collagen vascular disease, or they haven't really gotten better with supportive care and removing the underlying trigger, such as in a granulomatous disease like hypersensitivity pneumonitis or sarcoidosis. In those situations, we can consider steroids or immunosuppressants. So the only time that we'll really use these is to prevent the further damage of the lungs, the further fibrosis. We can't repair or remove whatever happened. And in those situations, you can consider this in sarcoid or hypersensitivity pneumonitis to really shut down that remember, again, when the immune system's super active, it's releasing cytokines, activating neutrophils, activating lymphocytes, coming to the area, propagating more inflammation, activating fibroblasts to cause fibrosis. If I suppress the inflammation, I can potentially suppress further lung injury and further fibrosis. So I could use this in granulomatous diseases or where they're going to continue to have attack by their immune system by situations such as scleroderma, GPA, EPA, and Goodpasture syndrome. So think about that. We can use these drugs. There's one other potential thing that we could do. In the same way that we could shut down inflammation, preventing further lung injury and further fibrosis, what if we just shut down the fibroblasts in a disease like idiopathic pulmonary fibrosis? We don't know what these patients' underlying cause is. So we have a patient who has idiopathic pulmonary fibrosis. We think it could be due to smoking, so obviously telling them to stop smoking would be great. Giving them supportive care like pulmonary rehab, oxygen, and, if need be, infection control. They are not going to benefit from a reduction in inflammation because that's not their problem. We don't know what their problem is. We can consider antifibrotics. We can shut down the fibroblasts and say, hey, fibroblasts, no more fibrosis. So we have to prevent the further progression of the disease, the further degree of fibrosis. That's all it's going to do, preventing the progression. We can consider things like pirfenidone and nintedanib, which is going to inhibit the fibroblasts from causing further fibrosis. Unfortunately, especially in idiopathic pulmonary fibrosis, we've tried everything. We treat the underlying disease or try to reverse it. We provide supportive care to these patients with pulmonary rehab, oxygen, and infection control. If they do qualify for steroids or immunosuppressants, we try that. If they're in idiopathic pulmonary fibrosis, we can try antifibrotic agents, but oftentimes these patients' lungs are so damaged that we have to unfortunately do a lung transplant. And that would be the last line of treatment for these patients and probably the best treatment for these patients with restrictive lung diseases. Engineers, in this video, we talked a lot about restrictive lung disease, but guess what? We're not done. We had to do some cases and really put to practice what we learned. So let's go ahead and do that now. So we're back. We're going to start doing some more cases. Now we're going to talk about restrictive lung diseases. All right, so first things first, we got case study number 1. We got a 35-year-old African-American female presents in an injury clinic with dyspnea and dry cough. Past medical history is pertinent for Lyme's disease. Now, when we look at the physical exam of this patient, very, very important. We have bibasilar crackles, which is the classic features, general features of interstitial lung diseases. Nodules, particularly on the shins. We also appreciate a violaceous kind of facial rash, ocular hyperemia, and right facial weakness. Very interesting here. So we have a patient who's young, middle-aged, African-American female. What did I tell you was a very important disease that was associated with this? It was one of the granulomatous diseases. This was sarcoidosis. Plus, it was very common in patients who had an underlying history of tuberculosis exposure or a Lyme's disease exposure. She has Lyme's. So she's fitting a lot of the epidemiological kind of features of that. She has some of the general features like bibasilar crackles. She has erythema nodosum, so the nodules on the shin. She has the lupus pernea, which is the violaceous facial rash. She has ocular hyperemia, likely indicative of anterior uveitis, and she has right facial weakness, which could be indicative of the seventh nerve palsy. So very, very interesting types of features here of sarcoidosis, it seems. So 92% at rest, so not really hypoxic. Respiratory rate's normal, heart rate just actually a touch low here. So 36 beats per minute, that's actually a touch low. And then blood pressure is relatively normal. So very interesting. What could be the cause of this low heart rate? It could be an AV block, right? It could have been from the past medical history of Lyme. She was actually treated for it, but it also could be due to sarcoidosis depositing within the AV node or bundle system that causes an AV node block. So very, very interesting, right? So likely an AV block. And that was one of the things. Remember, it can cause restrictive cardiomyopathy or it can cause AV node block. So which one of the restrictive lung diseases do you suspect? I am leaning more towards the sarcoidosis in this situation. What labs should you check for this patient? Remember that granuloma makes high levels of ACE, so check ACE levels. And they're also going to have a lot of that alpha-1 hydroxylase enzyme that's going to help to activate vitamin D and then really help to amp up the calcium levels. So you'll see hypercalcemia, high vitamin D levels, and increased ACE levels on these patients. So how else would you go about diagnosing these patients? Well, first thing, do the PFTs to support more of a restrictive lung disease case. So what do we look for? We look at the FEV1, slightly low, but the FVC is significantly low. So when we put this into the ratio, the bottom number is low, increases the overall number, so it's going to be greater than or equal to 70%. Residual volume into the lung capacity. The lungs are really small. They don't want to expand. They don't want to bring air in. And so they're very tiny lungs. So decreased total lung capacity and decreased residual volume, more supportive of restrictive lung disease. Check the DLCO. Remember, in these patients, if it's very thick respiratory membranes, there's some type of problem with the respiratory membrane itself due to fibrosis or granulomas or some type of parenchymal lung disease of its nature. It's intrinsic. That's more suggestive of an interstitial lung disease. But if it's normal, it's more likely nothing to do with the intrinsic or parenchymal lung disease. It's something to do with the chest wall, something to do with the muscles, it's something to do with the nerves that are supplying the muscles. So that would be situations of the pleural disorders like a massive pleural effusion or a pneumothorax. It would be situations where there's some type of neuromuscular junction type of problem, so Guillain-Barré syndrome, myasthenia gravis, or like myopathies, or some type of like severe weakness of the muscles. It would be something that's actually due to like the chest wall deformities, so ankylosing spondylitis, scoliosis, or maybe even some type of severe obesity. So in this situation, it's low, more suggestive of an intrinsic type of parenchymal lung disease, and that comes down to granulomas. It comes down to pneumoconiosis. It comes down to collagen vascular disease. It comes down to drugs. And then again, from there, we can also say it could be idiopathic. We don't really know the cause. So with this patient, I think we do, and we're suggesting it's a granulomatous cause, such as sarcoid. One of the things that we would do is get a chest x-ray or a CT scan of the chest, and it would really give us a good look at that bilateral hilar lymphadenopathy. They would also have that kind of like reticular nodular opacities maybe within the lung tissue itself. So you would get this classic type of interstitial lung disease presence where they have these kind of like interstitial reticulonodular types of opacities moving from the central to the periphery. This is a very classic interstitial lung disease look. If you were to get the patient's CT scan, again, you would find more of that interstitial lung disease type of look, very nasty kind of ground glass opacities that you would appear. Okay, very, very common of interstitial lung disease. And again, the reticulonodular opacities. The other thing is that you could see honeycombing. This is pretty common in interstitial lung disease, but very, very suggestive within idiopathic pulmonary fibrosis. So you can see kind of like this like little honeycomb look that you see here out on the edges. All right. So if you did what's called a bronchoalveolar lavage, and you took a biopsy, particularly of areas near the lymph nodes or near the actual parenchymal lung tissue, and you checked it out, and you're looking at the lymphocytes, remember those non-caseating granulomas are going to pop up. So you would pick up non-caseating granulomas if you did do a biopsy, but on top of that, if you lavaged out some tissue, it would be rich in lymphocytes. And so you'd have a very high CD4-CD8 ratio for these patients, okay, and non-caseating granulomas. So definitely supportive of sarcoidosis. So I think the big thing is how do you treat these patients is usually supportive. You can kind of, consider just steroids at some point in time if they need to be on DMARDs. You can also consider that. But I think the other big thing to think about is that there's one particular thing to think about with treating interstitial lung diseases. And there's a idiopathic pulmonary fibrosis. In that situation, you don't really know the cause. It's suspicious that it could be due to increasing age or it could be due to smoking, but in these patients, you don't really have a cause. So what you want to try to do is stop the fibrosis of the lungs. And so in these situations, you can give them drugs like pirfenidone or nintedanib, and this would be things like idiopathic pulmonary fibrosis. All right, so what I want to do is instead of going through cases, I want to really help to test your knowledge and see if you guys remember this, because this is a key thing that you're going to see on your exam that'll pick about which type of interstitial lung disease it is. So let's save some time and help you guys to remember. So if I have some exposure and I'm working in an industry that has sandblasting, mines, or foundries like metal factories, which one am I most susceptible to? Coal workers, asbestos, silicosis, berylliosis, or hypersensitivity? It's likely going to be silicosis. Okay, if I have some type of exposure for shipbuilding, plumbing, or roofing, which one would it be? Asbestosis. Whoops. And then if I have some type of work in aerospace industry, electronics, ceramics, tool dyes, and manufacturing, it would be berylliosis. And then the last one, if I'm working in coal or carbon mines, it would be coal workers pneumoconiosis. And then if I'm working as a farmer, maybe and I'm exposed to pigeon droppings, spores from barley or hay, what would it be? Hypersensitivity pneumonitis. So remember these and be able to match those up with the patient's history. The other thing is important to remember is which lobes are likely involved in these patients who have these pneumoconiosis. So if I had the first one, which would say like coal workers, that always involves the upper lobes. And then you have, which one? Asbestosis involves the lower lobes, more of those pleural plaques at the bases and mesothelioma. And then silicosis and berylliosis should involve the upper lobes as well. Which kind of complications or organ involvement is also really, really key here that'll help you to pick out the interstitial lung disease, right? So we talked about some of those, especially with sarcoidosis, but let's go back and see if we can figure out which organs or complications they may present in the clinical vignette that would point towards which one of the interstitial lung disease causes it would be. We already know the exposures for the pneumoconiosis, that's key, but what else would be important that would help us? So first thing with we looking at all of these and testing these out. If I have a patient who's very high risk for TB or they have calcified lymph nodes on their biopsy, this would be more suggestive of, remember that eggshell lymph node calcification? Silicosis. If I have a patient who has risk of mesothelioma, bronchogenic carcinoma, and they have these basilar pleural plaques with ferruginous bodies in their sputum, it would be more suggestive of asbestosis. If I have a patient who has calcinosis of the skin, sclerodactyly, telangiectasia, Raynaud's phenomenon, it's more suggestive of scleroderma. If I have a patient who has rhinosinusitis, they have glomerulonephritis, they have C-ANK antibodies, this is more suggestive of Wegener's or granulomatosis with polyangiitis. If I have a patient who has asthma, allergic rhinitis, glomerulonephritis, and P-ANK antibodies, that's more suggestive of EPA, eosinophilic polyangiitis. And last but not least, if I have a patient with hemoptysis, glomerulonephritis, and anti-GBM antibodies, it's more suggestive of Goodpasture syndrome. So think about those, especially if they present that in the clinical vignette. All right, my friends, that covers restrictive lung disease. I hope it made sense. I hope that you guys enjoyed it. As always, until next time.